Hi, everyone. Thank you for coming to today's presentation for the Canadian Managed Alcohol Program study. We're really excited to have Becky and Mary from the St. John's Status of Women Council's Managed Alcohol Program. They just celebrated their 1-year anniversary, and they're going to give us a little bit of an update on where that program is and all their successes and some challenges, I'm assuming, about getting that program off the ground and keeping it going. So without taking up more time, we're going to pass it on to Mary and Becky.
Hi, folks. Just as Brittany said, we're really excited to be here today. We've been really looking forward to talking to this group and sharing some of what we learned, because I'm looking around at the names of people here and we've already learned a ton from you folks already. And there are many of you here that I'm sure we've spoken to already just to get our program off the ground. So my name is Becky. I am the Harm Reduction Coordinator for the Managed Alcohol Program, and our MAP is couched under a greater organization of the St. John's Status of Women Council here in Newfoundland.
And I'm Mary. I'm the researcher and training support with the MAP program.
So we're making an assumption here, obviously, that many people in the room know a little already about what the managed alcohol approach is. And I'd like to note that, we said that we've just finished up the first year of our pilot and that we are the only harm reduction program for alcohol in this province, in Newfoundland and Labrador. So yeah, again, knowing that folks kind of know what MAP is, we'd still like to go through a couple of things that we kind of ground our program and our work in. So participants in our MAP are generally provided with a safe and stable supply of alcohol, specifically to reduce harms from their alcohol consumption. But we're not just an alcohol-based MAP. We connect people to resources to support their health and social needs as well. So housing, food insecurity, case management, primary health care, etc. We also know that MAP isn't for everyone, but rather quite specifically for people that are using alcohol in a way that's causing them significant harm. So some hallmarks of what we see could be non-beverage use, illegally obtaining alcohol, being involved in the criminal justice system, dangerous withdrawal, and other things. But one thing that is really important to us in our intake process for MAP is that we're factoring other social harms in here as well. So we are not just looking at alcohol direct related harms, but also things like homelessness, total income loss to alcohol, whether or not someone has access to food, gender-based violence, and sex work that the participant is categorizing as harmful. So not all sex work, just what folks is saying feels risky or harmful for them. So we have seen to date that MAP is a great option for folks that feel like they've exhausted all of their other resources available to them, especially when it comes to a more traditional treatment approach. But also for those who are unable to access treatment for a variety of reasons or barriers. So since we're a small pilot, we've had the luxury of being able to try out a bunch of different approaches and models of MAP to really get a sense of what our population needs and what our region needs here. And it allows us to evaluate a wide variety of harm reduction options. So we are a very short pilot. Actually, we are a 2-year pilot project funded by the Substance Use and Addictions Program through Health Canada, which is a program that I'm sure many are familiar with here. So we are currently only funded until March of 2023. So before our MAP was MAP, it's really important for us to note that this project actually came grassroots out of Marguerite's Place, which is the supportive housing program that's with the St. John's Women's Centre. So Marguerite's Place actually started doing MAP with somebody to creatively meet a resident's needs and to give them safer options in their community. So Marguerite's Place, their dedication to this approach and to harm reduction is really why we are here today. We wouldn't exist without them starting that really off the side of their desks. And it's great that now, on top of what Marguerite's Place was able to offer, we're able to serve a fulsome MAP to other women and non-binary people in St. John's. So we're so glad as a team to be bolstering the resources available and taking it off the sides of people's desks. So our program is also a partner program. So it is a partnership between the St. John's Status of Women Council, but across multiple other things. So we are partnered with our regional health authority is called Eastern Health, and Eastern Health during COVID began a harm reduction nursing team. So that's grown quite a bit since then, and now includes pharmacist, mental health support, a nurse practitioner. And we work in kind of like loose partnership with them to help us out with assessment, with intake, and with offering primary care to people as well. We're also partnered with a family physician that does some work with our downtown health collaborative. Her name is Françoise Gagné, Dr. Françoise Gagné. And she was actually the family doctor of the person who Marguerite's Place was supporting when this was a pre-pilot back in the day.
We've had an incredibly busy, but such a rewarding first year of this program. So kind of give a lay of the land of what we were at. So first we got our funding, and after we secured that, we hired our team. So you've already met Becky, who's the coordinator, myself, the researcher. We also have a case manager, an outreach worker, and some relief staff. Then we went to work, mostly myself, researching maps across Canada, looking at the literature, talking to a lot of local folks with lived expertise to get that local context. And we use this research and the input of folks and knowledge within the team to develop considerable program operations and policies. So it was a lot of upfront work, but we felt that was really important to ensure the program had a sustainable foundation that was really rooted in harm reduction policies. We opened our referrals in the fall of 2021, and candidates were assessed for eligibility by MAP staff, the healthcare team, and the candidate themselves. So it's sort of a roundtable situation. And the first participants were onboarded in early December of 2021. When participants are onboarded, MAP staff, the participants themselves, and the healthcare team collaborate to create care plans that centers the participants' goals. So not everybody that comes to our program has the same goals. They might have goals including drinking less alcohol, increasing their food security, increasing their safety while doing sex work. And then the participant and prescriber determine the amount of alcohol and the method of access that's going to support them in meeting those goals. Typically what that looks like for us is participants receiving alcohol between 1 to 3 times per day, either by coming to our locations and picking up, or our staff delivering it to them. Participants meet with the MAP team regularly to ensure that the program is continuing to meet their needs and their goals. We've also participated in a lot of reciprocal knowledge sharing with other MAPs, community organizations, healthcare professionals, governments. We want to share as much knowledge as we're able to, and also receive that back. And then 2 really exciting initiatives that have come out of this year that staff put so much work into, and they're absolutely incredible, is the harm reduction peer group and our community advisory committee. So the harm reduction peer group is facilitated by staff with lived expertise, which was really important to us. The group is open to current MAP participants and the wider community. So it's more of a general harm reduction group rather than just for our participants. They meet twice a month to discuss topics of the group's choosing. So what that has looked like has been substance use, grief, trauma. There's been a lot of stuff around parenting. And sobriety is not a requirement to attend. We've tried to make it as low barrier as possible. The attendees share a meal, and it's really a space just to get together, get support from one another, and we've had great feedback from participants. And then the Community Advisory Committee has been developed to inform the direction of our MAP program, support us in securing stable funding, and there's members from community organizations, external MAPs, healthcare, and government from across Canada on that one.
Okay, sorry. So we recently took some time a little while back when we kind of thought of doing a 1 year in reflection. So we took some time to reflect together with our healthcare partners on what it's like to build this partnership so far. It was no small feat in cooperation developing this program together around a common goal, but also something that we were coming up again time and time again was coming from different lenses of practice and having different resources available to us. Because our healthcare partners are not joining us here today, I'd like to take a little bit of time to represent what the providers have brought forward to us as what they feel have been our most critical learnings together to date. And I've expanded a little bit on those from our own experiences as well. So first, one thing we heard from the health folks and we agreed on together was the real need for an individualized approach with MAP, and specifically with this population of women and non-binary people. So we found, especially when looking at this from a gendered lens, that the harms experienced by our referrals and participants are uniquely different and often quite more numerous than some experienced by other genders. So even within that, each participant's context is different from another, and what they might need from this program could be completely different from what another participant may as well. And it might even be different from what we're researching and learning about in terms of a classic MAP participant. So having flexibility here and committing to that as a program has been really integral to the success of our participants so far. So we don't feel that a large scale standardized MAP would be as effective of an approach. And we've seen that both in research and in practice so far. So you really need the resources to individually tailor the care plans. We also heard from our health folks on the importance of meeting people at eye level. So we cannot predict, presume, or impose what people need just by assessing where they're at. So it's a lot more important that we found to give people trust, empathy, and validation. And then we often find that people not only feel valued, but then empowered to actually tell us what they need, and us not being in charge of that. So we're giving people a chance to take charge of their healthcare, and we're just the facilitator of that is kind of how we view ourselves in that process. And then from a healthcare perspective, we as a group have been pretty astounded that this program has made it possible for people to access primary healthcare in ways that they wouldn't be able to otherwise. So MAP in that sense has inherently increased physical and mental wellness for participants. So speaking to access to emergency service, including EMS, I guess, in hospital, in general, what we learned in research is that MAP decreases emergency service involvement in people's lives because there's proactive work being done around withdrawal and over-intoxication and addressing alcohol-related health concerns through our program. But when emergency services are involved, our participants have a team of harm reduction advocates that are working around them to give them access to equitable care and making the process hopefully a little less stigmatizing. So we've seen several participants so far that have been completely alienated from the health system and isolated from that, who are now actually actively working towards physical wellness goals and mental health wellness goals. And they tell us that this couldn't have been possible for them without MAP. So moving away from emergency healthcare and just talking about primary care, we've seen this as a really invaluable service from the harm reduction team. So being tethered on an as-needed basis to a team of harm reductionists practicing nursing and medicine has allowed participants to approach their health goals from an angle that's a lot more realistic to them and without judgment. So even participants that have family doctors, because we do have a few folks in our program that are otherwise connected, the deal is that their family doctors may not understand or agree with their alcohol and substance use. So even those folks can still access the harm reduction nurses to talk about or work towards their vision of wellness without duplicating care. So we're pretty discerning about this, but we're making it work, I think, without unnecessarily removing folks from an existing circle of care that they might have outside of MAP. I think that one of our greatest feats so far as a small, lightly resourced pilot has been the amount of partnerships that we've been able to create, both internally in our organization and in the wider community as well. So it's something we're really proud of. So we already mentioned earlier our connection to our internal program, Marguerite's Place, because Marguerite's Place was really the birth of the pilot project. And even today, Marguerite's Place remains a really important part of our service delivery. So they actually provide us with a residential option for MAP for women and non-binary people who also need supportive housing or who need a more involved and present version of MAP than something Scattered Site might offer, because our program, our MAP itself doesn't have our own housing, but Marguerite's Place does. So Marguerite's Place is also a satellite site for alcohol dispensing for people who prefer or find it safer to pick up their supply rather than have it dropped off. So some people might not have a safe place from which to have their alcohol dropped off. There is another community organization in St. John's called Thrive that is currently also acting as a safe dispensing satellite site for MAP for a woman who seeks services from them and feels really safe there. Thrive staff are trained in safe dispensing by us as well, which is pretty cool. It's, you know, kind of outside of our own umbrella, but they've been fabulous partners. This organization, Thrive, also participates in street outreach in the community, and we've been joining them in that effort as well, just to have that kind of alcohol harm reduction lens on the ground with them. We also have had a bit of partnership with the new Nunatsiavut government in Labrador as well. So we've done some mutual consultation with those folks on indigenizing our own services. And also with them and the Health Authority in Labrador, LG Health, on developing their own map. So that's been really reciprocal to date, and we're really glad we know them. We also have a program through our health system called NavNet, which is short for Navigating Networks. And it's basically this really intensive case management program, I guess. And they're involved in one of our MAP participants' care and are acting as a moving satellite site for us right now. So if they engage with a participant in the community, they are able to dispense alcohol. And all of their staff have been dispensing trained by us as well. There is a local women's shelter in St. John's for young women, the Naomi Center, that worked with us in a very cool way to support a participant in their shelter. So they partnered with us for dispensing and support, even though their staff found it quite difficult to kind of get around the harm reduction lens. We were really able to come together for the needs of the person. And a community health center in St. John's, the Gathering Place, and our End Homelessness, so End Homelessness St. John's, both partnered with us together to provide emergency temporary COVID services to a woman who was isolating for COVID. And we were able to get her what she needed to safely isolate from others, which was a safe supply of alcohol. And then I guess my favorite partnership, what I think is an interesting one, is there's a local brewery in the province that provides us with our participant alcohol supply. So it's a custom beer brewed to participants' tastes and tailored to their ABV needs for their prescription. And the brewery they've been awesome. They've really helped us work on making this an empowering experience for our folks, and even had one of our participants design the label and name the beer, which is a really cool partnership. So I think there was a picture of our beer, a couple of slides back there, that has artwork by a participant, and the title is written in Inuktitut, which is her first language. And what it translates into is, what is it? Look, a little delicious drink, which we thought was really cool.
So this map, excuse the pun, it just illustrates all the connections and partnerships that we've made beyond our local context in St. John's and right across the country. We just want to highlight and take time to thank everybody who's been able to offer us knowledge and help us to make our program as good as it's been.
So to share a couple of points on what we learned so far, knowing we're only a little over halfway through this pilot, we've had, knowledge coming at us left, right, and center in both easy and difficult ways. So one big thing that continues to be something that we're working on is our referral and intake process. It's very much still a work in progress. So we're still trying hard to find the balance between reducing barriers to entry and speeding up access to services, while also requiring a significant amount of information and assessment material for our providers to feel safe and confident in prescribing MAP. So that's been something that we've been consulting with some other MAPs on as well. It's been a hurdle for us. We've also found that we needed to really individually tailor our intake model based on the context of the referral. So some folks might be a really straightforward MAP participant, while there might be others that we stay connected for, sometimes for a couple of months, to support them to either be in a place where MAP is accessible and safe, so working on readiness, or doing some diversion and exploring other options with them that they haven't been able to date. So just having a harm reduction approach to seeking other treatment has been an important thing for us to offer to people. So this sort of MAP diversion and interim support was a really unexpected learning point for us, but also one that we are really glad to offer and we've felt is quite important. So we know that many community programs, if you're not kind of a black and white fit for what they serve, are in a position to say, sorry, why don't you just try somewhere else? Whereas we've seen great benefits to staying modestly connected to individuals to help them reach their harm reduction goals, even if those goals are outside of MAP. So for several of our participants, taking the time and the energy to build trust, even over a matter of months, has been critical to their success in MAP and their readiness for this intervention. Another broad learning point for us has been in the model of practice. So there are many different types of MAPs, and we've pretty much given them all a shot at this point. So we've done some work with residential in-house at Marguerite's Place. We do primarily, I would say, scattered site outreach MAP in the community, satellite sites as well. So like we mentioned, our partners earlier, and even for one person to creatively meet their needs, we engage in on-site consumption. So that differs from supervised consumption in some ways that we're not kind of policing their use. We're just kind of giving them a safe place to be able to drink. So a big part of our evaluation and continuation of the project will, of course, be taking a look at which of all of these models we can sustainably continue, and then where to focus our efforts on building capacity in the community for other models elsewhere. Because it really is our hope that other people in our province and in our city will pick up MAP and run with it. And something else that we've learned a lot about that we've spoken about a bit already has been gender-informed care. So to our knowledge, please somebody tell us if we're wrong, but to our knowledge, we're the only MAP we can find that does not serve men. And we clearly see and recognize the need for MAPs for men in Newfoundland and Labrador. But we're also in a fortunate position to develop a program that's gender appropriate and affirming for women, including trans women and non-binary people. So as we talked about earlier, marginalized genders face pretty specific and unique harms that deserve targeted support and attention. And if they don't receive the targeted support and attention, they slap you in the face, that's for sure. I don't mean the people, I mean the harms, you know, they're very much in your face. So we're really glad to be operating in an organization that sees the need for this distinction, actually, even though the mandate can feel limiting sometimes, we're proud of it. And we can't wait to share with interested stakeholders what we've learned about providing gendered harm reduction, really. Because we recently consulted with another MAP in Halifax to discuss building their capacity for MAP services geared towards women. And we really hope to do more of that work, even outside of MAP and just harm reduction in general, meeting other genders besides men where they're at. Our experiences with participants so far have been really cool, really varied, especially in their goals around MAP. So to break down a couple of numbers, we've had 15 referrals to our pilot so far, 7 of which have been at some point engaged in traditional MAP services, and 2 of those being what we call a harm reduction participant, to whom we don't provide alcohol, but we provide resources for food security and both residential and individual support. So sometimes, you know, when we have referrals come in, we see that people are being greatly harmed or at risk related to their alcohol use, but in consultation with our providers for a host of reasons might not be the best idea to provide that person with alcohol, but rather support their harm reduction in all other areas. Yeah, but it's a pretty nuanced, I guess, way to provide care. So 6 of these folks in our bigger number are somewhere between referral, assessment, increasing readiness for MAP, or working with us on some diversion from MAP, looking into other treatment options. So to speak to some of the goals that we've helped people work towards so far in MAP that really stand out to us, one that's come up several times has been using MAP as a bridge to treatment. So stabilizing alcohol use can allow people to feel in a place to consider to access other treatment options. So we've been really excited for participants who have used MAP in a way to reach their abstinence goals, which is definitely not something we require or expect, but it comes up. So for one individual, this meant that they started with us, and we quickly realized that it would likely be a situation of palliative MAP. But since stabilizing with us, being able to address a lot of their physical healthcare concerns, this person has since accessed out of province treatment and has returned home. So they see this as a pretty huge success for them. We've also seen the goal as MAP as an avenue for choice. So for one participant of ours, their main goal of MAP actually was to be able to make a decision and be able to say no to what they were categorizing as really risky sex work for them. So this person was quite entrenched in their alcohol use. So we use, I would say, like a true harm reduction approach of safe supply rather than something a little bit more managed. So they can choose to access their alcohol from us rather than feel like they need to engage in survival sex work just to avoid withdrawal symptoms. Also, we've been working with some folks using polysubstances. And what we see is often their goals in MAP is to find stability in one substance to be able to access some stability in some of the other drugs that they use, which is cool. Something that we continue to learn that we've spoken a little bit already is that all of these experiences required a gendered lens to help us evaluate what people need and what the definition of safety is there. I mean, I'm a little bit biased, but I feel like we've had a lot of interesting participant experiences around people's goals. But these are some that really stood out to us. There's many more. But the reason that we like to go through these is there isn't often a lot of research or evidence on typical MAPs. And a lot of these things aren't showing up in the research we see. So we like to be a little bit loud about it.
So like I mentioned, we did a lot of work up front to ensure that the program would have a sustainable foundation. And from this, some significant knowledge products were created. So the first was a jurisdictional review. So this looked at the academic literature, consulted with a lot of other MAPs, like I mentioned, probably some folks in the room, and interviews with local people with lived expertise. The literature and existing MAPs offered evidence that, I mean, we know this, folks, that MAPs improve the healthcare and social outcomes of participants, and we learned best practices from other MAPs. And the lived expertise interviews offered incredible insight into the realities of the drinking culture here in Newfoundland and Labrador, the various harms experienced by chronic alcohol consumers, and what supports people are looking for. The policy and practice documents. These include alcohol provision, application packages, satellite site procedures, documentation, working alone, call policies. So this might sound like a lot for a really tiny program, but we want to make sure that our staff and our participants are safe and as supported as possible. Individuals with lived expertise informed each of the policies. The feedback was sought out through interviews, focus groups, and in really creative ways. So we had one of our staff just like go down to one of the organizations that serves vulnerable populations. So they like serve meals and have groups. And she sat down the group with them and gave them our application package, and they absolutely ripped it apart. And it was the best feedback ever. We also have community and clinical assessments. So potential participants go through assessments, both with the medical team and MAP staff, to determine if the program is going to be able to support their goals. These assessments are in-depth, maybe too in-depth sometimes, and led by the participant to get a wholesome understanding of their needs. And when participants are receiving alcohol, they are assessed at each dose to determine if they're eligible or not to receive their alcohol. And then we have a harm reduction workshop. It's currently internal right now to the St. John's Status of Women Center staff, but it's 2 hours covering the principles of harm reduction and practical applications within our work. You've heard about what we've been at in year one. What does year two look like? Which I can't believe we're here already. We want to expand the pilot. So we've been working on that, doing some really creative outreach to increase our reach to populations that we might not be seeing yet. We have the capacity to expand to approximately 12 participants, so we're hoping to get some more applications in. We've also seen the expansion of our harm reduction peer support activities. Initially, the group was only for our own MAP participants and people who had submitted applications, so it connected with the program in some way. But we've now expanded to be open to the wider community. And our staff have begun doing some really creative work in reaching other populations. So they've been doing pop-up groups in community organizations. So they'll go and have a pop-up group, have a meal, and meet with new people that way. We have our community advisory committee, which I mentioned, to offer direction to the program and aid in securing some permanent funding, hopefully. We've been doing some program evaluation, so measuring the impact this program is making, mental and physical health, patterns of alcohol usage, consumption, and emergency service usage. And then provincial resources for MAP, because we want to share what we've learned. Like Becky said, we hope that other people take up the torch and have MAP in across St. John's for other genders and across the province for everybody else. We want to be able to share, what we've learned there. Securing stable funding. Like Becky mentioned, again, our SUAP funding ends in March of 2023. We are actively pursuing funding from federal, provincial governments, the private sector. We see so much value in the program and want to ensure our participants and others in the community experiencing harms from alcohol have stable and consistent harm reduction supports.
So we optimistically, but importantly, see ourselves as beyond 2 years as well. So we want to keep doing this work for as long as we can. So we've got some dreams, and some of the things that we dream about are as follows. So we know that this project actually fits right into the direction our province is going in terms of a continuum of treatment options for people who drink. So the recently released Provincial Alcohol Action Plan for Newfoundland and Labrador pretty directly speaks to MAP as part of a continuum of treatment and services and supports the development of provincial guidelines. Unfortunately, though, I will say that funding for MAP is not expressly outlined in the 5-year plan, despite the fact that MAP is already happening in our province. And of course, permanent or extended funding is something we're working on this year, but we're also seeking additional funding to what we've been running on the pilot to date. So funding to further support existing and future options for the program. So one thing that we see is important is having more harm reduction based supportive housing for marginalized genders. So we have some learning with this already in Marguerite's Place, and now it's a matter of deciding if harm reduction housing is part of what we do in that program, or if this housing merits its own program within MAP, so its own residential component. And I mean, this is a no-brainer for us, but safe consumption services. There are no safe consumption or safe use sites in Newfoundland and Labrador. So this program, when MAP was first conceptualized in this organization before my time, it was always intended to act as a little baby step, or I mean, maybe it's a big giant step, towards anti-stigma work in the community that would help our province see this need and foster the service for safe use and safe consumption. And then something that we would really love to see is us supporting the expansion of MAP across other populations, other regions, etc. So we do not intend to singularly hold MAP, especially because our region and our population is niche. So we're really focused right now on providing as many resources, learnings, and experiences as we can to those who choose to take up this work alongside us as well. We left quite a bit of time in this presentation to have some discussion because we know that this work is common to a lot of the people in the room, and we figured we've probably got lots of things to learn for each other. So please throw them at us. You can either unmute or in the chat.